Thanks very much. It's really a pleasure to be here. It's always a good meeting to attend, and I always learn a lot from the sessions. So I have no disclosures. If, as someone who trained about 20 years ago, I were to give you the history of the world and how it relates to GBM, it would be something like this. There was a big bang. The Earth was created. Dinosaurs roamed the Earth. We all know what happened to them, and that's a cautionary tale for all of us, I think. That was a joke. At some point in the 70s, there was a brain tumor study group, sequence of studies. And then there was this length of time when we were, I think, all collectively spinning our wheels, not much going on. And as was alluded to, within the past 10 years or so, some things have happened. And I think it's an encouraging thing where we might have finally begun to find a few cracks in the wall on GBM. And so it's a lot more exciting to talk about it, I think, nowadays than maybe it was 10 or 15 years ago. So let's get started. The objectives will coincide with the outline of the talk. We'll just start by reviewing, of course, some essential basic facts. Go from there to review how we got to where we are in terms of what we think of now as a conventional or traditional management paradigm. We'll think about a few developments that are beginning to lead us in the direction of something of a personalized medicine approach towards GBM. And then finally, we'll finish up with an acknowledgement of some of the very interesting and novel and arguably disruptive strategies that have come about and have received a lot of attention in the media. So to begin, I think everybody knows that GBM is a very bad tumor. The lethality of it is notable. Very few patients live past 5 years. It accounts for about half of all primary brain tumors. The characteristic pathologic features are described as pseudopalisading necrosis or microvascular proliferation. And by that, I mean it's perhaps a little bit better to see in this particular extra sketch here. The pseudopalisading effect is meant to be a situation where at the edge of the necrotic material, there's a streaming of cells which are on their way to death, and they are a result of some problems in the vasculature. And there's just a classic without which not diagnosis is made. As far as the molecular genetics that have been worked out, I put this slide up there perhaps more as an introduction to some of the speakers to follow, because although there's been a lot of work and progress made in understanding some of the genetic alterations which go into the process of diverting a stem cell towards GBM or one of the other lineages in the astrocytic range of abnormality, I think as you'll see later on that some of those other genetic alterations and pathways are a little bit more prominent as we actually go down the grading system to 3s and 2s. But in any case, it is definitely the case that there have been at least a few good clues about what to do here and there. For instance, more commonly in peds, but occasionally in adult tumors, you'll see a BRAF mutation, which is of course targetable by the number of drugs that have been developed in the melanoma world for targeting that particular set of mutations. But in any case, progress being made and understanding becoming more and more available to us to attack things from different directions. I would just bring to your attention that there will be an Astro Guideline on GBM management, and it's currently in development, but there will, as always, be a period of public comment, and so it might be a good thing to look out. Dr. Chakravarty is one of the co-authors on that particular effort. The key studies that are being addressed are very reasonable ones, and I think ones that we all like to have clarity around and occasionally have refresher on, and that will be: when is radiotherapy indicated for GBM? What sort of dose fractionation schedules are good to use? What sort of target volume should we approach? And what is the role of reirradiation? I won't specifically attack each of those questions in this particular presentation. Perhaps indirectly some of them will be addressed, but I would just encourage you to stay tuned for that particular guideline to come out, and you would be welcome to offer your comments when it comes to the public comment period. The title of the talk included the word gliosarcoma, so I feel obliged to mention just a tiny bit about that. Gliosarcoma is a much less common subset of the entire world of grade 4 brain tumors, and as you can see from a SEER database analysis published a few years ago, it accounts for only maybe about 2% or so of the grade 4 primary tumors. Overall, if you were to step from the back of the room and look at the survival curves, you probably wouldn't think that there was a huge difference, and ultimately the gliosarcomas are always wind up being clumped with GBMs in any way. But drilling down, at least in this particular SEER analysis, if anything, controlling for all the usual suspect variables of age and extent of resection, et cetera, gliosarcomas might even be a worse tiny subset of this particular group. The characteristic features of a gliosarcoma would include not only to see some aberrations and some malignancy developing from a glial cell line, but also in parallel with that to see something of an abnormal and neoplastic nature arising from a mesenchymal origin, if you will, and there's a need to have some special stains which corroborate the independence of those two lines of development living alongside each other in this very bad acting tumor. This is just one example of a somewhat more recent single institution series from UCSF. Looking overall, the survivorship, not too surprisingly, reflects what might be expected for a GBM version and a more glioblastoma-like version, the former being marginally better prognosis. But in any case, both being readily clumped in all the studies that we'll come to after this, along with GBMs, and so we won't specifically differentiate them anymore apart from that. Okay, let's just refresh our minds about how we got to where we are in terms of how to manage GBMs and what we know and think we still need to know about that. Everyone, I think, is probably familiar with the original brain tumor studies, which set the stage and have really continued to be relevant even 30-some years later for management of GBMs. There were a series of studies, the most notable of which, published in 1978, included about 300 or so patients with high-grade gliomas. Now, there were a couple of grade 3s included in there, but the vast majority were glioblastomas grade 4. They were treated either with a gross total or a subtotal resection and randomized to one of four arms: best supportive care, BCNU, radiotherapy, or radiotherapy plus BCNU. The radiotherapy itself was whole brain radiotherapy, 50 to 60 gray over 6 to 7 weeks. It would have been, in the case of the skull I showed to the left, looking something like that. It's a bizarre skull. If anyone recognizes it, I don't think it's a HIPAA violation to say whose skull is that. That's King Tut. That's right. That's King Tut, readily available. Okay, there now there are 3 people awake, because there was at least three people in the audience now awake. That's good to know. This is by way of reviewing material that would have been, I would say, canonical to those of us who trained around the same era that I trained, because this is in fact what we had to go with, and not much more than that. This particular landmark study result, which established that, yes, radiotherapy as an adjuvant to surgery gives you about 5 or 6 months of added overall survivorship. Really a little bit more suspect or whether that particular chemotherapy agent did or didn't add a whole lot to that. In the particular publication of the paper, in the 1978 publication of it, there are a couple of subset analyses, or a couple of secondary analyses, if you will, one of which would have been a valid study group, another one would have been an active treatment group. In modern terminology, that would have been recharacterized and reclassified as something called a landmark analysis. If you looked at a landmark analysis of this particular study, in other words, it only considered people who would have lived long enough to have received the treatment or have received that length of time after surgery of best supportive care, the differences are a little bit sharper and come out in a little bit stronger relief. But in any case, I think you see that what you have here is a modest benefit, not a home run by any means, but something to go with and something to build upon. There were other studies, in fact, that were done asking the question in slightly different ways, but more or less the same question of surgery plus minus radiotherapy. A meta-analysis published in the Green Journal in 2002 would have indicated to you that, looking on balance at the whole body of literature published as of 15 or so years ago, there was in fact an overall benefit towards favoring postoperative radiotherapy, and that reached a level of significance with a hazard ratio of 0.81. We've arrived at a little bit more refinement in our approach from a technical perspective. Limited field radiotherapy is much more the norm nowadays than whole brain radiotherapy. There was, in fact, a randomized study also done by the Brain Tumor Study Group to ask a question of comparison of whole brain radiotherapy plus a narrower field of treatment. The question of how do we get to our currently accepted dose on the order of 60 gray in conventional fractionation would have been addressed in a Medical Research Council, a British study, also published around that time, in which a dose of 45 gray and 20 fractions was compared against 60 and 30, and a modest benefit to the additional treatments. The 60 gray arm did a smidge better, and that led to our current understanding of that particular strategy of approaching it. There are, not surprisingly, a number of SEER analyses that are out there. This one just happens to be from our group, but I don't think it's the only one out there on this particular topic, looking at a population database analysis. Once again, I'm just approaching the question of what does radiotherapy appear to do or not do in this population of primary brain tumor patients? The vast majority of the patients available for analysis in SEER are GBM, and a smattering of the lower grade tumors also present. Perhaps not surprisingly, we saw a modest but significant survivorship benefit for patients who did receive adjuvant radiotherapy in both GBMs and in grade 3 primary brain tumors, as you can see right there. The question of whether or not best supportive care is or isn't as good as radiotherapy has actually been asked again in what some would consider a much more contemporary or closer to current day series, published in the New England Journal, no less, a number of years ago. This is in the elderly population, 70 years of age or older. The radiotherapy in this case was 50.4 gray and 1.8 of fraction to a partial brain field. And you can see, fortunately, refreshingly, and comfortingly, that we are still doing some good. We think we're still doing some good for the folks in this population, because there was definitely a significant bump in progression-free and overall survivorship with the radiotherapy arm versus best supportive care. Now, the wheel spinning that I think has gone on since a lot of those initial brain tumor studies has been ambitious, well-meaning, well-intended, very logical, and very reasonably based. It just hasn't really paid off so much. There was a number of studies trying to figure out ways to use a boost of one sort or another with brachytherapy, accelerated treatment. A number of hypoxic cell sensitizers sort of came and went, and particle therapy is still certainly investigational in this context. But despite all the strenuous and energetic and enthusiastic and sincere efforts, not a whole lot had been able to be bumped as far as results are concerned. So the NCCN guidelines, as you would find by a quick check, simply endorse a fairly standard radiotherapy schedule in this situation, 60 gray and 1.8 to 2 gray per fraction, and of course to do that alongside chemotherapy. We'll speak just about the chemotherapy for a minute. I think everybody's so familiar nowadays with temozolomide. Perhaps just for historical purposes, we will maybe just discuss for a second or two the era before temozolomide chemotherapy. There was one. There was an era when other agents, BCNU and some parallel agents, were being tested. A meta-analysis of those particular experiences, published on the order of 15 or so years ago, looking at the 12 or so randomized trials involving a chemotherapy versus no chemotherapy randomization, were looked at. The upshot of that was that, as a matter of fact, on meta-analysis globally, in the pre-temozolomide era, there was a little bit of a bump to the survivorship curve. Temozolomide had not yet really been tested against one of these older agents. By comparison with how much better you do nowadays with Temodar versus other agents, I think most people are not going to go back and ask that question necessarily again. But in any case, it's worth just acknowledging that the pre-temozolomide era was, in fact, modestly helpful. At least some bump to the survival curve was being achieved with those agents. Of course, there was still a recognized need for further research. Everyone would be familiar nowadays with, of course, the study that appeared on the scene. It's now actually 10 years old, the radiotherapy plus or minus adjuvant temozolomide study, published in the New England Journal. It was published by a fellow named Roger Stoop, the lead author, and there's an interesting picture of him on Cancer World magazine asking the question, what's so ethical about strangling research? And I have to agree with him. I don't think we should do much more research into strangling. I just don't see the value of it medically, and I don't think our tax dollars should go in that direction, because I wouldn't. Yeah. Okay, now we have about 40% of the audience possibly awake, and maybe the coffee's sinking in. They did, in fact. Okay, good. I think everyone might already be very familiar with this study. There were nearly 600 patients randomized. Most had had a resection. Some had just had biopsy. The radiotherapy is what everyone I think would consider a fairly mainstream standard approach, 60 gray. The arms to which patients were randomized included temozolomide or not, and in the schedule that you'll see right there, concurrently on a daily basis with the radiotherapy, and then adjuvantly thereafter on a modestly different schedule. And I think everyone was relieved to see a good bump in the survival curve here. There was a bump that might have been modest if you look at it only in terms of how much median survivorship was gained, but I think if you look at 2 and 5 year results, it feels as if there might have actually been a bit of a legitimate elevation on the plateau, I should say the late phase of that survivorship curve. And so So everyone welcomed that as a good thing, especially because that particular agent is rather easy to give, modest toxicity profile, and if for no other reason than that, improves upon, I think, some of the older agents on those lines of comparison alone. And so there we are, about 30 years or so after the original brain tumor study group, with something that I think people at least felt a little bit fresher about, and at least began to be a moment of thinking maybe people are, maybe we have a chance at rethinking our approach to DBM and could maybe refine things from there. So towards that direction of trying to refine things, the first way I think that came about was really a careful reanalysis of this particular study and some similar studies, looking at the MGM story. And so here is a very simplified version of the MGM story as told by someone who's by no means an organic chemist, a biochemist, or a medical oncologist, or anyone necessarily qualified in the realm of DNA repair. I don't have in-depth, extreme knowledge of that, so I'm going to give you what I suppose is the layman's view of understanding the MGMT story. So MGMT is also called O6-methylguanine DNA methyltransferase. It is an enzyme involved in DNA repair. In particular, for alkylating agents, it repairs the damage inflicted by that category of agents by removing some of the alkyl groups from the O6-guanine. When the promoter for this particular enzyme is methylated, there is a lowering of MGMT expression, and when MGMT expression is lower, there is an extra effect of alkylating chemotherapies because you don't have so much of this particular escape mechanism, this particular stress recovery mechanism in place. So makes sense. There's much more elegance to the detail of that I couldn't possibly do justice to. But I think as a 30,000-foot or 5,000-foot view of this, it helps me to think of it just in those relatively simplified, I hope not oversimplified terms. The analysis of how this particular enzyme and its expression plays out is shown here as an analysis of that same study, that same Stoop trial. If you look, first of all, at the left-hand side, this is a separate parallel publication from that same study. You can see that MGMT, just stepping back from it, appears to have a prognostic impact overall, because when you find it methylated, when you find there to be less of this particular enzyme to protect from damage around, survivorship is simply better. If you drill down a little bit, and I apologize if those curves are a little bit too much blending, but if you drill down a little bit in the better prognostic group, if you will, in the patients who've got MGMT promoter methylated, i.e. less of this agent around, it is also predictive for temozolomide benefit. In other words, in that subgroup of patients who got temozolomide did noticeably better, whereas, unfortunately, in the other on the other side of the coin there, you can see that it did not prove to be a differentiator for other outcomes in patients who did not have promoter methylation. The question could be asked also, what about the radiotherapy piece of this? Is there a way to drill down and see whether it's also predictive for a radiotherapy effect? It's a little trickier there. I mean, of all the things that radiotherapy does, well, I should say that for alkylating agents which target a more narrow range of toxicity types to DNA, if you will, it might be a little bit easier to find an agent that you can have a predictive test for. Radiotherapy, as we all know, is a much broader mechanism, if you will, and although it may do some alkylating effect, it doesn't necessarily do that exclusively, and perhaps that's why, as you'll see, it doesn't necessarily turn out to be quite so predictive if you try to drill down just on the radiotherapy question around that. So there are a couple of studies which I think inform that question to some extent, both published in the Lancet Oncology a couple of years ago, both asking a question of single modality adjuvant therapy in older patients. The first being a German study, where the randomization was in older patients, 65 years of age or greater, after biopsy or resection, either plain old Gard-Vanella 60-gray radiotherapy or temozolomide. Separate from that, there was a Nordic study published around the same time, 3 arms, plain vanilla 60-gray radiotherapy, a modestly hypofractionated regimen, and temozolomide alone as a third arm in that particular study. If you look at the results of that, first of all, I would say that the key result from the latter of those 2 studies would be that in older patients, first of all, that particular comparison of fractionation schedules did not make a huge difference, so you can feel a little bit more comfortable, especially in an older population, with using a somewhat more accelerated fractionation schedule. All of those 3 arms in that particular study came out about the same. If you were to drill down once again and look by MGMT status, there was a little bit of information to take out of the combination of these two studies. And on the left-hand side, you'll see the representation of the German study, the NOA-08 study, whereby you can see that for patients who were methylated, who in other words had less of this enzyme, there was once again a predictive value to the use of temozolomide. Not so much of a difference with or without methylation for patients treated in the radiotherapy group. So those are the separations. The two overlapping arms of the radiotherapy arms didn't seem to matter whether you're methylated or not so much. Likewise, from the Nordic study, a parallel result, confirmatory, I believe, where you look at in the temozolomide alone arm, once again, a predictive value to the test, and not so much for radiotherapy. I think if you put these two studies together in total and wanted to take-home message, I think it answers a very important desert island question. If you are on an older patient with GBM on a desert island and can only have one modality of treatment, if your tumor is methylated, you probably want to go for temozolomide, otherwise a short course of radiotherapy. And I think that's about the take-home message we can take. Much discussion has been around the relative shortcomings of these particular studies, because maybe they should have included a combined modality arm. They didn't. That's just the way it was. So at face value, this is something that can be taken from it. And as we struggle sometimes with our older patients and look for a path of least resistance in many cases when we're a bit suspect about whether a patient is robust enough to tolerate a fully aggressive therapy, the studies may not have been perfect, but I think they were at least a little bit helpful. We do, to some extent in our own clinic, use this information occasionally to sway ourselves to decide on what to do about it for a patient who we think maybe can only handle one or the other modality and perhaps not both. Okay, well, let's just talk a little bit then about what's at the frontier and what has attracted some of the headline news and where's that going. So first of all, let's start with what's an unavoidable, surprising, didn't see it coming sort of result, which is that there was a study of a device called at that time the Novocure Novo TTF, since renamed the Optune device. And it was a randomized study reported about a year or so ago at the Society of Neuro-Oncology, and caught a lot of attention because I think, I will admit to you, I would not have predicted this particular result, a positive result. And I'll try to explain as best I can what this device is about and how it works and what the results were, with the same caveats that, as I mentioned, MGMT, not being organic chemist and not being a sophisticated DNA repair expert, I don't, in this case, either presume to be an expert on the entire mechanism. I think it's a mechanism we all have to learn a little bit more about, because it was, I think, off most of our radars, I would have to say, until this particular study was done. But in any case, the essence of this particular device and how it works, as best I can tell you, is that there is an interference with many of the processes of mitosis. There is a lot of interference with microtubule organization, if you will, by a disruption of some of the electrical fields around the cancer cells, which do have some influence on the process of cell division and replication into two cells. There is a mess up, and some of the cellular effects of this particular process of alternating electrical fields have been likened to the process that might be observed after taxane treatments. In other words, a microtubule agent. And to me, that's at my first pass of this, that's what I'm going to go with, is my own understanding of what appears to be the underlying mechanism involved. In any case, this particular device is something that a patient wears on his or her head, and it's sketched out there in some of the pictures you see right there. I should first of all acknowledge that I'm indebted indirectly to Dr. Stoop for these particular slides from this presentation. A colleague, a mutual friend, colleague was shared them with me, so I do want to acknowledge that. These are not my slides that I'm sharing with you right here. They're the ones from the SNO meeting from last year. In any case, you'll see that the patient is, as I mentioned, obliged, has to be a bit motivated to wear this particular device for the majority of the day, and carried around with a little bit of a backpack, as you can see right there. But in any case, the upshot of it, after a very clean randomized study design, was that there was a
overall progression-free survival benefit. I don't show you that curve right here, and also an overall survivorship benefit of several months. And so it is not to be trifled with, given that all the other things we've done to throw at GBMs have been deemed major successes if they bump out the survival curve by 2 to 3 months, and that's about what we're seeing here. And so I think it's something that I can tell you, are still trying to wrap our hands around to figure out exactly how we incorporate this, and are we going to begin to use this all the time, really, for every single patient or not? And I can tell you we haven't necessarily settled in our own group consensus on that, but we are thinking carefully around that. I'll mention one thing that's in the purely radiotherapy domain, partly because Helen is here and she knows that there was a little bit of interest in a special topic which speaks to radiotherapy target volumes, and it came about because of a couple of papers that came out in the Red Journal in late 2013, and they're highlighted here, and what they showed was this. There has been in the background in some preclinical experiments and also some clinical correlative experiments, an awareness, a notion, a suspicion that there could be some stem cell harboring regions within the brain that might be particularly important to be aware of in the context of treating GBMs. The subventricular zone of stem cells is considered a potential source not only of reseeding or refeeding or repopulating GBMs, but also might have a bit of an indirect effect in terms of providing cytokines which nurture the growth of neoplasms in the brain. And so published in the Red Journal, more or less in parallel around that same time, were a couple of studies which suggested that the dose given to this particular area, this region of the brain, could be relevant. And it could be the case that when patients get higher doses to this so-called subventricular zone, you'll do a little bit better because you are either inhibiting perhaps the repopulation of the tumor from killing off some of the stem cells, or one of those other indirect cytokine-mediated mechanisms. Now, to be fair, I will say that both preceding and following these particular studies, a couple of, how shall we say, counterpoint studies have come out in the literature. I'm not sharing them with you here, but I'll just say that there have been those who have looked at institutional experiences and come up with a different suggestion or a different observation, shall we say, where either the dose to the subventricular zone did not make a difference, or it even might have, in 1 or 2 cases, suggested an adverse effect. And it's open to questioning whether or not what we're seeing here is accident, anatomic. Perhaps some of the ones that are located in this region might be a little bit more amenable to treatment or resection. Be that as it may, hats off to the Johns Hopkins group who are going to tackle this particular challenging question with the randomized study. And so it's listed on the clinicaltrials.gov website, and you can find out details of that. The structure of it is rather simple and clean in that sense. I hope it becomes clean. I hope they get some good enrollment to this particular study. The experimental arm, quite simply, is conventional radiotherapy in the way you would ordinarily do it, but a specific awareness to treating the subventricular zone where the stem cells are thought to be harbored. And the comparator arm would be the same without particularly paying attention to this particular subventricular zone. So it is a testable question. It could inform how we begin to redesign our target volumes if it were positive in that direction. And so we await the results, and I hope those folks do well in their recruitment efforts. Okay, it's hard, unless you're living under a rock, not to have heard something about the poliovirus in recent weeks. And if you haven't had a patient come in to ask you about what's up with the poliovirus, then you must just not see GBM patients, because I can't count. It's the odd patient nowadays whom I've seen in the past couple of months, ever since a high-profile 60 Minutes piece on this topic, who doesn't ask about who doesn't ask, or whose family member does not ask about that. And so let's just talk about that for just a moment, because I think it's worth having an awareness of that. So the original science of the notion that poliovirus might be something interesting to work into the treatment paradigm or to exploit in some fashion or another as a direct or indirect means of targeting and treating glioblastoma extends really from even some work published in the mid-1990s by this fellow, Matthias Gromeyer, but I'll jump ahead to a study that was published about 10 years or so ago, which I think illustrates the essence of what the original thought around the use of poliovirus for GBMs might have been. And so you can see here in this particular publication that what is meant to be done here is that by simply infecting in the laboratory at least, GBM cells, a number of cell lines with the poliovirus, you will get a process of so-called oncolysis. In other words, there will simply be a blow-up of the cells. And so the top line here on the right side from that particular figure is a control effect where the left-hand column is, I think, 0, then 6, and 12 hours after the introduction of poliovirus into the culture of one or another of those cell lines that you see listed on the row ahead, B through G there. The middle column and the right column are 6 and 12 hours afterwards. And it's probably not projecting particularly well, but what you can see there is a very profound effect, at least in vitro, that simply the presence of this particular virus, which in fact has a receptor that appears to be somewhat preferentially expressed on certain primary brain tumor cells, having that virus in there blows up the tumor cells. Now, the way this is playing out and being done clinically may or may not be a reflection of that exact mechanism. The study that was a phase 1 study and will be, I think, followed by some additional phase 2 and perhaps even phase 3 studies headquartered at Duke University at the moment, perhaps to be spread beyond that, is a study in which a number of patients with recurrences have had an infusion or injection of a poliovirus containing solution. There are a number of very encouraging and very provocative and dramatic sometimes effects and sometimes very durable effects simply from the infusion of this agent. One that is on their website and was featured in the 60-minute study is shown right here. It's a young woman who has had about a 9 to 12 month or so effectively progression-free survivorship just from the infusion of this. Now, the actual mechanism in patients, I think, is maybe open to some further investigation. There is some question around whether it's simply an oncolysis effect, as would have been suggested by the very early preclinical stuff, or whether it's a bit more involved and a broader immune-mediated effect, because certainly by having a virus in some area of the brain and some area of the primary brain tumor tissue, there are a host of immunologic mechanisms which are invoked, and maybe that's the real effect that we're hoping for. But it's a story worth following. I think it's at its very early stages. I think it's an outside-the-box approach that's worth applauding, even if we are all now obliged at least to counsel our patients that it's at the very earliest juncture of its experimental history, let's just say. And while we are, of course, looking for and hoping for very good effects from this, I think there's a limit to how much we can conclude, I would say, from just this thing. But it's an attention grabber in recent times, and I think it's worth acknowledging and knowing about. So with that, I think I will stop right there, and I'd be happy to take any additional questions.
While you're thinking of the questions, let me start off if I could. Clearly, the 60 gray in 30 fractions has been there for a long time. And the radiation oncology field has moved on in terms of the machines, the precision, the delivery, etc. So do you think there's a reason in some ways in the general glioblastoma population to revisit that in some way, or readdress the question of, is that enough? Do we need to go higher? Can we do this lower? Chemo-radiation combinations. So just a broad question about it.
Sure. Well, as most of you probably know, the R2G is in fact investigating, once again, a dose escalation strategy, and it is a study which will compare 60 gray against a simultaneous integrated boost, which can either be done with photons or even with particle therapy. And so I think we're all, hopeful and anxious, and if there's a way to bump up the survival curve with a modest additional intensification, that would be a great thing. On the other side of that, a number of institutions have looked at intensifying the dose from the perspective of giving a shorter course with somewhat higher doses per fraction. We among them, but certainly by no means exclusively. We did a study where It was a phase 1 study to escalate up to a dose intensity of 60 gray in 10 fractions, and then a subsequent phase 2 study, and then a subsequent phase 2 study to that, doing the same thing with Avastin. I will have to say that our own experiences, our own personal institutional experiences would lead me to believe that we just might have a plateau effect of what we get from dose intensification of radiotherapy alone without a new, novel, clever biological agent. I'm not so sure, and maybe that's just because we butted our own heads into a brick wall, and that's about where we got. But by all means, I don't mean to diminish the enthusiasm of anyone else who's actively pursuing that, because we would welcome it if it were proven to be the case. If you're asking simply, can we do certain things and identify populations for whom a shorter and somewhat more convenient schedule is a good thing, then I would absolutely agree with you. I mean, I think we've seen a couple of examples of situations, certainly for elderly patients, 60, 65, 70 and above, who do not seem to suffer any decrement in their survivorship by a shorter and somewhat more modestly intense schedule. And that's an important lesson to learn. And I think that probably the Astro Guidelines will come around to presenting that data in a good way that will, I hope, guide people to know that sometimes you might as well just take your foot off the gas a little bit, because we might be in diminishing returns by pushing everyone to a full 6-week, 60 gray schedule. So, sorry, Leighton or Arnav, I don't know.
Great talk, Dr. Kavanagh. I have a question about the Stoop Optune study. Somewhat surprising results, I agree with you. First question is that various microtubule inhibitors have been tested already in glioblastoma, I believe back in the 1990s, small studies without really any significant results. How convinced are you that that's truly the mechanism of action versus some other mechanism? And second, that was a phase 3 study, wasn't it? So has this really changed the practice in the United States, or are people largely ignoring that study right now?
That's a great question. And first of all, I don't know if there's another mechanism involved. It's still an interesting observation, and perhaps a random chance observation. I mean, I couldn't prove that it's not. We have not yet figured out how to do this. I mean, even though we participated along with a lot of other people in the study and put some number of people on that study and on the precursor study, which was in recurrent GBMs. It takes a motivated patient to comply with that particular device. It involves shaving your hair and wearing something that looks a bit like a hat, sort of looks like a hairstyle. It's a bit. You can wear a wig over it. Yes, it's true. I don't know what the uptake's going to be on this, because it's an interesting thing, and I think the jury is way out on that. Have you thought about that at your own institution and processed it?
Yeah, I think we had the study open at our institution as well. I'm not sure that it really has dramatically changed national practices. I was just curious. That's 3-month survival advantage in GBM is not insignificant by any stretch.
Right? That's, yeah. Like we're all still scratching our heads, I think, collectively about what to do about that. Yeah, I admit.
Thank you, Brian.
Yeah.
Leighton Pang, Honolulu, Hawaii. Thanks, Brian, for the excellent presentation. Do you have any comments on the role of SRS, if any, for GBM? And secondly, do you have any comments on IDH1 mutations and its future use?
Sure. So to the first question of SRS, there's an RTOG study, negative study. It's interesting. Kudos to, there was a group, and I believe it was, I believe the first author was someone named Ireland. It's a dimmest of memory here, but there was somebody I know who went on record about 6 or 7 years before the RTOG study was completed, looked at a fairly large institutional experience, and I believe it was one of the Canadian institutions. I apologize if I'm getting this wrong. Looked at a sizable experience on whether or not SRS did or didn't benefit, and on controlling for that, came to a conclusion that no, it does not appear to be, because it seems to be a slightly, it's more or less an anatomic selection benefit, if you will. The folks who wound up getting SRS had a little bit smaller tumors, a little bit more peripheral, a little bit easier to do, a little bit easier to resect, et cetera, and that probably explained the benefit. And so that person at least went on record as predicting the negativity of the subsequent studies to do in that regard. So although we use it ad hoc occasionally as one of the second-line therapies that we put on the table for folks, at one or the first or second or beyond recurrence, if it looks feasible, anatomical, or maybe surgery is not so easy to do. I don't know that it's an easy thing to fit into a standard upfront regimen, and so we don't personally use that outside this. I mean, there's obviously another reirradiation study going on, R2G, bevacizumab, plus or minus bev, plus RT. We have had that study open, I'll tell you, and have had trouble accruing because so many patients have already had bev at some point, and we have trouble catching them while they're still bev naive, I should say. But I hope that study accrues well, and it'll be interesting to see whether that proves reirradiation in a broader, that's 35 gray and 10 fractions. It's not exactly SRS, but still it's some reirradiation. It would be interesting to see how that shakes out. We're cheering for the radiation effect in that, of course, and I guess it remains to be seen how we do. I'm sorry, the next question was about IDH1. Yeah, I think that's going to, I'm going to bet that's going to come out a little bit more in one of the next talks. I think it's a little bit more relevant in slightly lower grades. We'll see. Sorry, yes.
Dr. Weiss?
Hi, thank you. That really was a beautiful overview. So my question is about the TTF. The randomized phase 3 trial in the recurrent setting, I think it was in the European Journal of Cancer. So it basically showed, I think it was 6 versus 6.6 month survival benefit. And so they basically called that a non-inferiority study. But I don't believe it was powered to be a non-inferiority study. I was wondering, do you have any particular take-home when you look at that?
I'll be honest with you, we have not incorporated that into our we prioritize other trials and such for the recurrent setting. And like I said, and one of my medical oncology colleagues, Doug Nye, who shared the slides with me because he has been more involved than I directly. He was our local PI for this particular study. Even he, as local PI, is still, we just still don't know what to do with it. I'll be honest with you. I hate to be so non-committal and indecisive sounding about that, but it's there. We're staring at these results down. Have you guys thought about that or incorporated that? Or
I'm particularly interested because we're looking to offer it to patients, and the thinking really for us is there's some patients who are not good trial patients because they're very compromised, but they're not dying. And the feeling is, at very worst, you're doing something that has very low toxicity.
That's fair. That's a fair statement. There's two other studies of interest in that particular device, I should say, one of which we decided not to participate in, one of which we decided to participate in. There's one that's going to be looked at for brain metastases.
Yeah,
we decided not to go for that because if that is the mechanism of action, let's just take it, perhaps it's a microtubule disruptor agent of some sort or another, which is fine. Our view on brain mets is just, we have just a different conceptual view of that where you're talking about there is that you're talking about reseeding events that probably happen, so you really need to do systemic things that reduce your circulating tumor cells probably to get there before they get there. So in any case, we chose not to do that. There's one in recurrent meningiomas after some number of prior treatments. I think we are going to do that because it's an unmet medical need when people, it's not a huge population of patients, but people who have a high-grade thing and you've pretty much exhausted all the usual regimens, maybe there's a role for it there too. If it looks good, that's
Thank
great.
you.
So we will put people on that study. Yeah.
Good morning, and thank you for the wonderful lecture. I have two questions. My first question is use of hypoxia sensitizers, especially in imaging, for example, 18F meso, and targeting those areas with a higher SUV value with an integrated boost. Your take on that? And my second question is, have you seen any difference of, using oral versus intravenous temozolomide, especially in patients who can't take oral temozolomide?
Okay, so to your first question, which had to do with hypoxic cell sensitizer, identifying hypoxic regions, that's been one of the tantalizingly appealing things to go after. And I think, the field of radiation oncology, classic radiobiology, looked at hypoxia as being this bad thing which interferes with your radiosensitivity, right? And certainly there's a body of literature that would support that that's the case, and that the presence of oxygen at low concentrations even stabilizes free radicals and all that sort of things. And yet I think GBM is probably an example, as are some other solid tumors, where the growing recognition that it's hard to know what's the chicken or the egg. Is the hypoxia the thing that comes first, or is it something else that caused the hypoxia? And is there a much more complex milieu of events that are happening which are driving the effects? My suspicion is more the case more that to be the case for GBM, that it's a bit like the frustration around bevacizumab, which is meant to normalize blood vessels and meant to prevent hypoxia to some extent. It has some palliative effect in terms of reducing edema, but there are ways that these tumors have to work around that. So I guess my general view would be that it's a temptation to think about, and by all means, I applaud anyone doing a hypothesis-driven experiment to figure out whether that is or isn't a beneficial thing. But if I were a betting person, I would still bet that that's not quite the final answer to solving the GBM riddle. And your second question had to do with
oral versus intravenous.
Oral versus, thank you. Every once in a while, we've had somebody who can't take a pill. It's just not too common, and so I don't know if we have a large enough institutional experience to say one way or the other. That's once out of every 30 patients, I suppose, we've used it. But if the person can't swallow it, obviously they have some other issues going on. So I'm not sure what to make of. Yeah, I think one person was a head and neck patient who might have, already had a G tube or something like that from a previously unrelated cancer from some years previously. But I can't say I have a large experience on that.